Good morning, everyone. I'm Dr. Bande. Today I'll be talking about COVID-19 treatments that are currently available. This is an evolving story, an evolving strategy. There are protocols available throughout the United States hospitals that doctors are using, but there is still a lot of heterogeneity to the treatment protocols. I want you to be empowered as American citizens so that if you had to navigate this for yourself or your loved one, you would be able to understand this and hopefully navigate it successfully. This is just a simple cross-section of a healthy lung, and microscopically then we see in a healthy lung there's a fundamental unit of gas exchange that happens and that fundamental unit is called the alveolus. It carries some capillaries, which are the blood vessels that absorb oxygen and let go of CO2. Within this alveolus, there is something called a type 2 pneumocyte. As we can see, there is an enzyme that this virus attaches to, the major enzyme, which is called ACE2. The purpose of this ACE2 is to convert something called ANG2 to ANG1-7. The whole purpose of this conversion is to essentially provide a relaxation of blood flow through your lung. Of course, the rest of your body, because this is not only on your lung, it's also in other organs in your body. It also decreases your risks of coagulation. So, what happens now when the virions attack the lung, entering through this lock and key mechanism on this type 2 cell in your alveoli? Well, as you can see, the whole architecture has changed completely. And of course, this is the virus doing a lot of the damage itself. But interestingly, when you eat up that very enzyme that was responsible for good blood flow, that was responsible for you having less risk of coagulation or of blood clotting, then essentially the opposite will happen. You will have poor blood flow. You will have more blood clotting. We see in, for example, the slide B on this histology slide that there's proteinaceous material. On slide D, there's inclusions in macrophages. This is the microscopically what's happening in your lungs if you suffered from symptomatic COVID. All right, so who are the folks that are at risk of getting this? Because now that we understood a little bit about what's happening to our lungs, both from the standpoint of what we lost, which is ACE2, and then the virus stimulating our immune system, the people who are at risk are the people who don't have a great interferon gamma response, who don't have a great cytotoxic T cell response. These are people, as you can tell, who have hypertension, diabetes, coronary artery disease. Amongst survivors versus non-survivors, hypertension was almost 50% in those who didn't survive. Diabetes prevalence was high in those who did not survive. Same thing with coronary artery disease. So what about those who have cancer? Cancer is also a very poor prognostic indicator. So if you had active cancer, 70 to 80% of them essentially presented with invasive ventilation in the ICU. If you had remote cancer and you've survived it, you are in remission, about half and half. And then of course, no cancer patients had more typical severe to critical symptoms that we've talked about in the 5 to 15% range. So let's talk about American data. This came out not too long ago, and it described the underlying diseases of those patients hospitalized from around end of February to end of March. And you can tell that 30% of those who were hospitalized did not have any conditions. 22% of those ICU admissions apparently had none of these conditions. And that's the line all the way at the bottom. So for ICU admissions, almost 80%. Now, this is the caveat. How many of those people actually were metabolically unhealthy? And of course, this is not an exhaustive list of comorbidities that we would consider chronic illnesses. Now, I want to make this connection with chronic illnesses and metabolic derangements, as well as ACE2. It has been found in studies that in these very conditions of heart disease, of diabetes, of high blood pressure, you do not find as much ACE2. You do not find as much ACE2, the very enzyme that will help blood flow and help you thin your blood as it flows through your lung, as it flows through the rest of your body. Metabolic derangements that are the underpinnings of these chronic illnesses that increase your risk for COVID-19 severity are reversible. Diabetes is reversible. Diabetes type 1, if you got it when you were 3, 4, 5, 6, 7 years of age, sure, you may need some insulin. Maybe even later in life, you may need some tiny bit of basal insulin, but beyond that, it is largely curable. Before we jump into the drugs used to treat COVID-19, let's talk a little bit about ventilation. Many of you, being entrepreneurs or scientists, have actually even started to figure out ways of how you could provide ventilators or assist in providing ventilators for hospitals. I'm not going to delve into why that's actually more of a problem of resource allocation rather than a problem of manufacturing more units. But I want you to get an idea of if a patient with COVID-19 would be entering the hospital having difficulty breathing, what would be the ways we would help provide oxygen, keeping in your mind those alveoli. So you can start with the nasal cannula. As you can see, the caliber increases as the mode of ventilation becomes more invasive. That's because the oxygen flow rate can be increased as the caliber is increased. The nasal cannula is quite low. We have the high flow nasal cannula on the top right, and then you have the BiPAP mask, which actually uses a ventilator, the same ventilator that you would use if you had an endotracheal tube. So it allows you to get the pressure that you desire in your lungs, because at the end of the day, that's what this is all about. This is actually fluid dynamics, aerodynamics, and you want to get a pressure that would stent your lung open. And the balloon metaphor is used a lot to try to push air in so that it gets inflated in your lung. And to do that, you need lots of pressure. And so you have to have a sealed mask around your face that's pushing air in, pushing oxygen, being the FiO2, fraction of inspired oxygen, in that air column. And the higher it is, the more you need it. So one of the things that you should be asking if you have any loved ones or yourself dealing with this is, how much oxygen am I using to keep my oxygen saturations up? Because in the ambient air, it's about 21%. These ventilation modes, you can increase the FiO2, and obviously you can get to 100%, which is all of that air is nothing but oxygen. And if you have that and you're still not saturating well, that is a sign of significant injury to the lung. Then invasive ventilation includes, of course, an endotracheal tube, which then, as I've just described, there is no dead space, or the dead space ventilation is decreased significantly. So instead of a mask pushing air into your mouth and esophagus and stomach, because it's the air is coming out from this hole, so it can go so many different places, it could leak out. The endotracheal tube would just have a little bit of dead space, would be a little bit like this, some of the bronchioles, until it gets to the alveoli. Compare that to all of this other dead space in the other modes of ventilation. That's why doctors are so quick to put patients on the ventilator when the oxygen status is not doing so well. And a little segue, a lot of the barotrauma that we're seeing because of this COVID-19 is driving ICU mortality. That means because so much pressure is being used to ventilate patients with COVID-19, that is causing a lot of damage to the lung as well. And that in of itself is adding to the morbidity, is adding to the mortality rate that's already so high, because we haven't found the most efficient ways to ventilate patients like that. I know there's studies out there for using surfactant. 50% mortality rate once you get intubated is unacceptable. Before we jump into the drugs, I want you guys to know what modern medicine thinks is a drug that can treat a condition. You may think that, oh, modern medicine thinks that it's just like a vaccine. I got a vaccine, I'm vaccinated, I'm immune. Well, you got your flu vaccine, but you still got the flu. Okay, yeah, you got measles vaccines, but you didn't get the measles. So uh, if you had hepatitis C, you had sofosbuvir and it cured you in 2 months. Whereas if you had HIV and you had antivirals 10 years ago, you could still have some of HIV left over. So what I'm trying to say is different drugs have different rates of successes. And for the lay public, it's hard to wrap their mind around what is an efficient and effective or even a rescue treatment. One would think that a rescue treatment would be 95%, 90%. That's what we would want to hear. But that is seldom the case. And most of the time, doctors would consider 60% success rate actually a good treatment. I know it's kind of hard to wrap your mind around, but actually that's kind of the benchmark that has been set. And so this is important because if in the future something is being rolled out and they say this is the treatment for COVID, and guess what? 60% of folks get better, they might tout it as a wonder drug. I'm not joking. This is serious because this is how big pharma works. What we don't want to be is fooled by big pharma or by anybody who's thinking they're going to come to our rescue. We have to rescue ourselves. We touched upon hydroxychloroquine a little bit. Data out there is poor. It's derived from quinone, and there's quinones, thymoquinones, so many different plants that it probably is helping a little bit. We were using lopinavir, ritonavir, which is a protease inhibitor. It can actually prevent viruses from replicating. Unfortunately, here in the NEJM study published a few weeks ago, it showed that it was essentially no better than control. We saw this in clinical practice. We saw that it wasn't having an effect. As far as tocilizumab, by the way, is an antibody that stops IL-6. If you stop these immune cells and the downstream effects of this inflammation to affect the alveoli, that hopefully you could have improved. But tocilizumab also, whatever few studies, especially out of China, it is equivocal data. We don't see that even 60 to 70% improving. Why might that be? That could be because you're already dealing with a 50% mortality rate. These expensive drugs are only really obtained when patients are doing so poorly. Now comes remdesivir. Interestingly, on Friday, NEJM, which is New England Journal of Medicine, just published data of basically a case series of patients, around 50 or so, who received remdesivir through the compassionate use program. That program, by the way, has been closed down because Gilead, the owner of remdesivir, has opened up a large clinical trial, which actually just increased from 400 to 2,400 patients. That's been ongoing now for 2-3 weeks. If it was a miracle drug, we would have already seen data. It's not a miracle drug. As you can see from here, 34 patients were invasively ventilated. Out of them, about 20 showed improvement. 8 of them were discharged. This is good, but there was no control group. This is just a case series, so you can take out of it what you may. The trial they're doing, I don't think has a placebo arm, which makes it even more difficult for us to interpret this data. This is a slide that shows, at least in patients that were non-invasively ventilated, that you had a much better improvement than those who had invasive, which was, maybe 40% again. But still, you don't have the mortality rate that you have without remdesivir. So this might be touted as a pretty big finding. Unfortunately, it's all about how we spin it. This is the culture of spinning, and we wait for how it's spinned for us, and we don't really take control of our own destiny.